Thank you for everyone who's registered and joined us today for this live Vulval Pain Society Q&A with Dr. Liz Venner, Associate Specialist in Dermatology at the Royal Cornwall NHS Trust. Thank you so much for being with us. So we've got about 26 questions that have already been sent in to us, and we're going to make best use of the time and get through as many as we can. And if we don't get through all of them, and Kay Thomas of the Vulval Pain Society is in the background and she'll be in the chat box answering questions too if she can, and anything left over we might do a follow-up or find another way of answering these questions, perhaps a future webinar as well. Okay, so Liz, you're a vulval dermatologist. Tell us first of all a little bit about how long you've been working in this field.
Oh gosh, going back to about 1999.
Okay, right, so you're definitely the right person.
So I've been doing it a while.
Fantastic. Tell us a little bit about the different presentations. So lichen sclerosus, lichen planus and other vulval skin conditions. Tell us a little bit, just briefly.
Well, so obviously when you're thinking about, I'm also a general dermatologist, and so I like to explain it that you've got skin conditions like eczema and psoriasis that can occur all over the body, but equally can occur in the vulva or the genital region in men and women. And then you've got the lichens, lichen sclerosus and lichen planus, and they tend to be more specifically genital. Not quite right for lichen planus, but certainly lichen sclerosus, specifically genital. And then there's a number of others. So that's your common. Sort of 50% of what I see in the clinic is probably lichen sclerosus and lichen planus. Then the rest is made up of itchy red skin, which could be eczema or psoriasis. Then we deal with vulval pain, of course. Then there's probably also a subset who've got precancerous conditions affecting the genital skin, and that's something called vulval intraepithelial neoplasia, which can also be painful and itchy and sore, but not always. And then there's lots of rarities as well, which, you know, the other things that can occur, sort of hidradenitis. That's not rare, I have to say, that's fairly common, but that could be a big problem as well. So it's a big variety of what I see in the clinic.
It's varied. Okay, so let's dive into some of the questions we've got, and they're varied too.
Yeah.
We'll start with, what cream can I use in this area as the vulva is so dry and extremely sensitive?
I think this is a brilliant question to start with. I'm so glad you did. I spend an awful lot of my time in the clinic talking to women about what they use and how they wash, and I ask all sorts of questions that often can have eyebrows raising. Why is she asking me what toilet paper I use? And I think basic skincare in vulval disease is the key to everything, I think, because the vulva itself is very different skin to the rest of your body. It's because of its differences, because of its the way it is physiologically different, it is much more prone to the effects of irritants. And therefore, even before you've got anything wrong with your vulval skin, you could have a problem just because you're using the wrong kind of products. And so I think time spent asking people about what they're using, except, for example, fabric softener in your laundry. Quite often fragrance is a common contact allergen, and you can imagine you're wearing pants that have been washed in fabric softener and then they're sat up against your vulva all day long. That could cause an irritation, and I make the true allergy is probably not so common, but irritancy is very common. So, for example, I'm not allergic to potatoes, but if I was to peel a sack of potatoes without wearing gloves, I'd probably have a rash on the end of my hands. So equally, the stuff that we get in contact with our vulva can cause a lot of problems. So in answer to that question, a bit long-winded way, I think it's really important, because get your skincare right and a lot of things get better before you do anything else. So things I always ask about: what loo roll do you use? You just want to use plain white, not coloured, not aloe vera or messed about with. If you wear pads, make sure they're plain and non-fragranced for sure. Try and avoid using fabric softener. If you're someone who likes using it, then just don't wash your pants with it. Where else? If you're going to use a lube for having sex, make sure it's a bland one that's not got any, colours or preservatives in. There's lots of good ones available now. And when you're washing, you need to. Something's just come up and decline. Oops.
There you go, you're back.
I'm back. I press OK. Sorry about that. Where was I? Oh, yes. Yeah, get the skincare right. So that I think is really important. So what cream can you use? One that is not going to be irritated. And the other thing I'd like to say is that we've just done a look at all their, so we patch test people in our clinic sometimes who've got problems with their vulval skin, because we need to make sure they haven't developed allergies to the products they're using. And patch testing is a common investigation that we use in dermatology, where you come in and you have the British Standard battery of things put on your back, left in place for 2 days, come back, have the patches off, and then come back for a final reading on at the end of the week to look to see if you've got any contact allergens. And we looked at all the women that we'd tested in Truro, in Cornwall, and about up to 45% had a contact allergy, which I think is quite high. And things, for example, that people don't realise, things like Sudocrem, there's an ingredient in Sudocrem that's a common allergen. You can sometimes become allergic to even the steroid creams that you're correctly using. So this is, as a general rule in dermatology, if people aren't getting better, developing a contact allergy is something that we always think about and test for. Oh, sorry, we've got a bit of a problem here. There you go.
That's okay.
So yes, I think it's very important. Get good skincare and a lot gets better without having to do much else.
And I suppose then, because we're talking about contact allergens and irritants, then it's individual to
very much so. Yeah, but I would say that the basic principles apply. Less is more, and when you're washing, try and avoid soaps, etc., and you use a soap substitute rather than strong soaps or shower gels.
Moving on to the next question. I'm diagnosed with lichen sclerosus and VIN. I use emollient and Dermavate for these conditions, but the pain is no better. Any advice there?
I think lichen. This is the number question 1. Lichen sclerosus and VIN. Yeah.
Yeah.
All right. So that's a tricky one, because both of them can cause. Why is the pain not getting better? Well, she may not be using the right treatment, or there may be an underlying neuropathic pain problem. So you can get pain in your skin because you've got red raw skin with splits and cuts. And equally, when you've got a condition like vulval lichen sclerosus, and this poor lady's also got VIN as well, there's many reasons why she might be sore and uncomfortable. This is quite tricky, because I think it takes a lot. There are many branches of ways you could go with this question. The way I look at it, that you can have a condition called lichen sclerosus, and that may be well controlled. So sometimes a woman will come to the clinic and they'll have LS, and before I've got to examine her, she'll be saying, I'm really sore, I'm really uncomfortable, the steroid's not working. And then I'll take her to the examining room and I'll look at her and I'll think, well, actually, it looks brilliant. What I'm seeing looks very good. The lichen sclerosus doesn't look active. It looks very well controlled. And therefore, I'm always now then thinking that she has what I call a secondary dysesthesia. So whereas when the skin is inflamed, you can see it because the skin is active and it's inflamed. What you have with a secondary dysesthesia is that because of the long-term nature of the condition and what it's doing in the skin, I like to think of it as inflaming the nerve endings in the skin, which you can't see. So if I see someone who's very symptomatic, very uncomfortable, but yet clinically I think the skin actually looks all right, I would be thinking along vulvodynia, secondary vulvodynia or secondary dysesthesia. So they require, you can't put a cream on a nerve ending and make it better. When we're using the creams, for example, the steroid creams, we're influencing inflammation in the skin. But that won't necessarily work on the nerve endings, and then sometimes other treatments that are required. But equally, if she has VIN, then we'd have to be I'd also be wondering, well, is there something going on with her VIN? Is that progressing, perhaps being a bit more active? Do we need to do a biopsy? She certainly needs to be seen, and it's right. When you have lichen sclerosus and VIN, I know times are difficult, but you do need to take that to your healthcare, your GP, right, and get seen, I would say.
Right. Okay, good. Next question. Is it still okay to use Dermavate, ointment and Aquamax and steroid creams throughout pregnancy?
Yeah.
Yeah.
Fine.
Great.
Yeah, easy. I mean, we still, yeah, yes, it's fine. It's a topical steroid, and that's what I love about dermatology. I'm just giving creams and potions most of the time. Yeah. It's not a problem, and we still treat bad eczemas in pregnancy and everything else. So yeah, that's fine.
Okay. And is there, whilst being pregnant, this woman is incredibly dry. Is there something you could recommend that might
This
help?
is a pregnant lady who's got a vulval condition or just very dry. Well, it doesn't quite fit physiologically, because when you're pregnant, you have so much estrogen. Your vulva is just usually very well, very engorged with blood, very moist. So if she's feeling dry, does she mean she's feeling sore and uncomfortable? Does she have thrush? Again, midwife, have a swab. Is there thrush that needs treating?
Okay.
I would think.
Okay. Now I know you've got a number of these questions, but we've had more sent in to us.
Far away.
A varicose vein appeared on my inner labia and a cut nearby. I've started estrogen cream for dryness, which gives a strange sensation. The cut isn't healing, and the itching has set off my vulvodynia, and the area looks red and angry. What would you recommend?
Well, it's not common to have varicose veins I mean, presumably I'm not quite sure what she means by a varicose vein. I mean, what I think and what she may be seeing may be different. So, but if she's got splits by a cut, does she mean she has split? Has she got any secondary infection? Again, that might need a swab and treatment. And if she's feeling dry and uncomfortable, does that mean she's dry and itchy? So again, not such an easy question to ask without seeing, because sometimes I have to, when people are telling me that what they think is a varicose may not be, or maybe so you can get some common vascular lesions that come up on the vulva called angiokeratomas, and these are just very benign groups of blood vessels that pop up on the labial skin, the labium, that's the labium majora, the hairy areas. Really common, just people get them, men get them on their scrotum, and they can look very like a varicose vein, because they're kind of that bluish colour. They can be bobbly, they can sometimes bleed. So does she mean one of those? They're benign, they don't need necessarily any treatment unless they are bleeding a lot, in which case we can sometimes cauterize them if they're a nuisance, which they can be, if a lady's on blood thinners for any other condition, then they can be a nuisance if they bleed. So if she's got a cut, that would mean a split. So splits would often be sore and dry. So again,
I think she can do then to
good cream. So a good barrier cream. And I never really fully answered the question whatever it was, which cream can I use? I love saying the best cream to use is the one you take the top off. So there are lots of different creams and many emollients to try, and that's why generally in the clinic I have a lovely cupboard full of small sample pots of everything, and I like to give everyone a good variety to try, because not everyone likes what I like. And then you can decide that the cream you find most comfortable, whether you prefer an ointment, a cream, a lotion, a gel, they're all different, and you need to use the one you like.
Okay, all right. I think the next one you may have sort of answered. Can you use hormone creams when you have LS, vulvodynia and vestibulodynia?
Yeah, and I think it's really important not to forget estrogen, topical estrogen. Again, topical estrogen is not HRT, it's just a cream. Like the steroids are not oral steroids, they're just topical preparations you can put on. And I think there's a good place, and there's no reason you can't use them, unless there are some conditions when you can't use them, if you've had breast cancer or other gynecological cancers. Actually, to be fair, even topical estrogens can be used, but you'd need to do them with a bit of advice, because there are some that are licensed and for low dose use, and they're fine. And I think it's really important, and that's something that can be overlooked, because I think there's so many facets of vulval dermatology, because you've got to think that this is an area you sit on, this is an area you pee, this is an area you poo, this is an area you have sex, this is an area you have periods. There's so much going on, and you've got to get every little factor right in order to get people more comfortable, which is why I bang on about skin care, the use of emollients, the correct use of steroids, and following on from that is also adding an estrogen if it's required. And I think if you get, it's just sort of adding little bits of everything to make the whole much better. And so yes, topical estrogen can be really helpful and really useful for those people who need it.
And with someone who's got a lot of atrophy as a result of LS, hormone creams to help tissue plumpness and quality?
Well, so yes, but also I'm wondering if in her question she said she's got a lot of atrophy. So does she mean that she's got very active LS still? In which case, i.e. does it look white and crinkly? That would imply that her LS isn't as best controlled as it could be. And therefore she might need to be using her steroid a bit more often, or even changing steroid if she's on a moderate potency to a more super potent one. If she feels that she's atrophic, i.e. lacking in estrogen, because she's having, I can't remember the age of this lady actually.
Actually 37.
Oh, well, that's quite young. So, I mean, it's not inconceivable to have early menopause. Obviously that needs to be thought about. But and
she does have regular periods, she says. Right.
So, I mean, there are some occasions, particularly after pregnancy, if you're breastfeeding for that first year after delivery, she hasn't mentioned that, but you can be a bit low estrogen. So my answer to that question is, what does she mean by atrophic? Is it that her LS is very active, in which case maybe that needs more attention? But yes, estrogen can help, even when you're 36 and not even menopausal. A bit of topical estrogen can sometimes help.
Okay.
And is safe to use.
All right. What is the management of paediatric LS, and what are the current recommendations for treatment?
Well, that is a good question as well. I would say almost exactly the same as I would in an adult. And I think there is a concern, sometimes I think that hopefully children don't have to wait long to get seen, because I think you do need to get in and make the diagnosis. And it's not so easy in children because girls often can present with, because you can get, obviously we know with LS it can affect the perianal skin. So often little girls particularly will present with things like constipation, because obviously the skin is thinned and it can often split. That means pooing can be really painful, and a painful pooing in a kid rapidly leads to them getting constipated, because no one wants to do anything that's painful. So getting it recognised is the first key. And I think there is sometimes a tendency to use too weak a steroid and be worried about using the stronger steroids. But to be fair, I would use exactly the same way of treating a child as I would, more or less, as an adult. And you want to get control, give them good advice, get control, and then you keep an eye on them and support them as they're growing up. Because what we want to prevent is scarring.
Right. Okay.
For future comfortable life.
Yeah.
As they get older.
So the next question, I have what looks like vestibular papillomatosis, and that's exactly where all of the pain is. How would this get better? Can it get better?
Well, it's interesting actually, because I think over the course of the years I've been working, a subset of women with vulval pain do have what I would call prominent vulval papillomatosis, or prominent Fordyce spots. And it's just something I've observed. I don't have any research or science to back this up, but I've just something else observed. So it is possible that might be a sign of increased sensitivity. In terms of treatment, I think the treatment is exactly as we would treat any vulval pain. We try topicals, we try drugs that can have an effect on nerve endings, we think about physiotherapy, we talk about good skin care. There's a whole range of things to work through, and indeed topical preparations to try, things like local anaesthetic gels, which can be very helpful, desensitizing, pelvic floor exercises, pelvic physiotherapy. I could talk for about half an hour just on that. But I'll keep each other way next to the question.
And so something like lidocaine 5%, that kind of thing is
yeah,
well.
Lidocaine 5% is it's a Marmite product. You'll either think it's wonderful or you'll hate it. It unfortunately stings. I mean, it's a characteristic of local anaesthetics generally that they sting. And I know I've been told by previous patients that I do paint a bleak picture. I said it might make you sting. You might be running to the toilet screaming, wanting to wipe it off after using it. I'm sorry if it is. And so consequently, some of them have told me they haven't used it because I've painted such a bleak picture of it. But anyway, it can be worth a try because it's a really quick fix if it works for you. But yes, it can be one of those stingy products to use. And that's why sometimes I've gone for using Instilla gel. So these are... Instilla gel is 2%. It comes in a syringe. It's meant for when we put catheters in bladders in men and women. It just makes so it's a bit more gloopy. It comes in a syringe, but you can sort of soak gauze pads with it, and it's a bit easier to have up in contact with your vulva. And some people find that they can tolerate that, whereas they can't tolerate the 5%. And again, used regularly, that can sometimes be used as a desensitizing agent. So gauze soaked pads or soaked cotton wool buds or whatever it might be. It's worth a go.
How are you spelling Instilla?
Instillagel. Instilla gel.
Okay. Okay, great. All right. My issue started after thrush treatment. Can the skin ever get back to normal?
Very good questions. This is another one. Oh, actually, I didn't mention that earlier when I say what I see in the clinic. So I think chronic thrush isn't necessarily well managed. So what thrush can do, everything gets blamed on thrush, doesn't it? So nearly every woman who comes into my clinic with LS has been told they've had thrush for the last however many years. Anyway, but it is common. It's a common thing. So and having thrush can sometimes set up vulval pain for a while afterwards as well. But also, if you're someone who unfortunately suffers from chronic thrush, it can it kind of sets up an irritancy in the skin. So you end up with kind of a dermatitis because of your chronic thrush, and then that's as much of a problem as the thrush itself. So just treating the thrush with an anti-fungal treatment isn't going to get you better because you need to treat the skin as well.
Right.
And also thrush comes, if you've got chronic thrush, then you're someone whose body makeup, if you like, your genetics, the way you are, has probably led to you having it, and therefore it's going to be even harder to get rid of it. So when I'm treating that, I tend to like using oral treatments for thrush to actually, so these are drugs like fluconazole, which will affect the thrush itself. But I also use a topical steroid that will help with the dermatitis as well. So there's things like Trimavate cream, Canesten with the hydrocortisone in, Canesten HC, that's the one in the blue packet, Trimavate, or even a cream called Lotriderm, which is good because that's a Betnovate strength steroid with clotrimazole, which is what Canesten is. And I think it's recognizing that you can't just treat the thrush and expect it all to get better. You do need to put some skin directed therapy in. And there we go back to what is your skincare like? Are you using emollients? Are you avoiding irritants and the appropriate steroid? So I think there's three basic principles for treatment. You need your topical steroid, if appropriate. You need your soap substitute, and you need your emollient. And I think that if you miss one of those three, then you're not necessarily going to be get as well as you could be. Not very good English, but you know what I mean.
Okay, it's a great question, a great answer. Yeah, thank you for that. All right, my pain is in the skin and is obviously red below the clitoris, but nothing comes up in test results. Why?
Well, I mean, if your tests are negative, I mean, what would the test be? That would be for infection. So it may be that you don't have anything like thrush. And if you have pain and you have red skin, that doesn't necessarily mean that you don't have a skin disease, or indeed you could still have vulvodynia. So I think a thorough history and an examination is important, because sometimes skin disease can be very subtle, and sometimes it can take a while to become obvious of what we're dealing with. I mean, I've a number of times I've sort of seen people with things over the years, and then finally they come back 4 years later and it's obvious that it's lichen sclerosus, but it wasn't obvious 5 years ago. So nothing is, unfortunately, dermatology diagnoses don't come with nice labels attached to them going, I am lichen sclerosus or I am psoriasis, and sometimes it evolves. And if you are, and there I'm back again. So in answer to that question, if she's got pain in the skin and it's obviously red below the clitoris, so in those cases she needs to be seen, to have an assessment, perhaps see a vulval skin specialist. In those instances when she may, I don't know if she meant that she's had a biopsy, because that could be, she could be referring to that in a test. Well, obviously we do think about biopsying skin again if we're not sure what's going on, because looking at the pattern of the skin under the microscope can give us clues as to the diagnosis. Or it may just be all pain, and that it just happens to look a bit red, because sometimes it can do. I mean, actually, the vulva, talking about that, the vulva, your vulva can look redder depending upon your skin type. For example, if you're a redhead type 1 skin, often your vulva will be redder.
Right.
Just because of your skin type.
Okay. Great. Okay. It's good to know. All right. The next one's a little bit of a longer question here. I've been diagnosed with LS 5 months ago. It was picked up when I was examined by my GP because I keep getting ulcers around the clitoral area. I've been on 4 lots of antibiotics in the last 4 weeks, but have suffered with these ulcers for years. Because they always burst before my GP sees it, they're reluctant to give a diagnosis of abscess, even though it bursts with pus. They've now given me Fusidin ointment instead of oral antibiotics. I don't know if I'm pronouncing that correctly. Are these normal with LS? My dermatologist said not, but probably an underlying lesion. My gynae appointment is postponed due to COVID-19. What can I do? It's really painful and difficult to manage. It can grow to the size of a marble, but I believe it swells underneath.
Well, I mean, most people have got access to smartphones. It's quite helpful if the lady feels comfortable. Take a photo when it's next active, because you can't always guarantee that you can be seen when it's active. So that's a good tip. Take a photo. As to what it could be, she's saying she's got visible things that swell and discharge pus. So that would tend to go against something like herpes, which you probably wouldn't. That doesn't sound like herpes, and herpes is very often very painful. There are, again, hidradenitis. I mean, and that's another thing. Just because you have a diagnosis of lichen sclerosus, a lot of skin diseases aren't mutually exclusive. You can have more than one thing going on at a time. So does she have another problem in addition to her lichen sclerosus? Hidradenitis is one thing that comes to mind. That's recurrent boils and pustules and abscesses, although usually more in the groins, not necessarily in the vulva itself. Again, sometimes, though, I was talking about we were talking about angiokeratomas, but another benign thing that you can get on the vulva are these sort of chalky cysts that can come and go. So it's difficult without seeing to know. But one of the ways that she could help her dermatologist or a gynecologist is get a good photograph of when it's rip roaring, so that she can show them what it's like in its active phase.
Okay.
I would think.
Right. With regards to steroids, should we use moisturizer before applying a steroid cream?
I think the debate has raged for the last half century, really, about which I think there is pros and cons for, but the practical point is I think it's probably easier to put your steroid, well, is this in the well, I tend to, for lichen sclerosus certainly, I tend to suggest you put the steroid on last thing at night and put your emollient on in the morning when you get up, so that it acts more as a barrier cream. I think it's whatever you, it's difficult. We all have busy lives. It's difficult to put on an emollient, wait for 20 minutes or 15 minutes and then put your steroid on. I don't think many of us have lives that enable that kind of attention to detail. Well, some may, but I don't anyway. So I don't think it really matters too much, and I would probably put the steroid on first and then the emollient on top.
Okay, all right.
But that you can do either.
Okay. What advice do you have for those who are afraid to use steroid for fear it thins the skin?
Right. So I do have got good advice for that, because steroid phobia is very prevalent, and most of the population are worried about steroid use. I like to put it in context, actually, of what, because it does seem to be a cultural thing. I think of the right word, but and it's both not just public and GPs as well. Healthcare professionals are phenomenally worried about steroids, and I think it all stems from when the steroids first came into use. It must have been in the 50s. They were like magic drugs. It was a magic drug. It suddenly cured everything that we hadn't been able to cure, and it was used for everything, and in all places where it shouldn't. And there were hideous skin thinning side effects on faces and all sorts of problems associated with it. And then there was this huge backlash. Oh my God, steroids are awful. Look what they're doing. You shouldn't use them. And that has stuck. However, in it appropriately used, I think steroids have a part to play. And sorry, I've lost the thread of where I was going with that. Are steroids safe? Oh yes. So in the context of lichen sclerosus, I think it is important to point out that the disease itself is scarring and thinning the skin. So, and this has been demonstrated in studies actually. So when you put the steroid on, you're reversing that process. So actually you're thickening the skin because you're reversing that inflammatory process which is trying to thin the skin. So therefore, and in the context of the vulva, you don't get skin thinning like you would in the crook of your arm or on your face. So in the context of the vulva, and in the context of a condition like lichen sclerosus, it is all right to use very strong steroids, and no, they don't cause skin thinning. However, if you get, like some women who get lichen sclerosus affecting their groins, so the groin skin obviously is away from the vulva, and it's what we call occluded because it sort of folds in on itself. It's a folded skin. And you can get skin thinning in your groins. So I'm very cautious about, often when I see women who've got LS that's affecting their vulva and their groins, I will give them the potent or super potent steroid for their vulva, but I will give them a weaker one for their groins. And I try and educate them and make the point about just being aware that you may get skin thinning in the groins, but not in the vulva. And there's one further tool I have to try and reassure people about steroid use. There was a study done. We know that in lichen sclerosus there's about a 4% risk of vulval cancer, and there was a study in Australia that was done a few years back that looked at followed up two groups of women. The follow-up group that were religiously putting their topical steroid on and use it regularly, and the follow-up group that were not, a bit more hit and miss. And she demonstrated quite clearly that the risk of further scarring and cancer risk in the group who were very regular about putting their steroid on was 0, and was greater in the group that were a bit more hit and miss.
Oh, right.
So
okay.
did that give us some evidence to suggest that yes, what we've always said, that regular maintenance treatment is the key to keep your skin condition under control, your lichen sclerosus under control.
And that.
So I mean that's because it's common. It's a common thing for people to be very worried about steroid use, but I like to try and explain, perhaps by talking about the historical aspect of it, but also why people are worried, but also to reassure them that in the context of lichen sclerosus, you don't really need to be worried, and it is the right thing to do. But I mean, whatever each person will need a different type of steroid or need a different strength. You don't always have to use Dermavate. It can be some of the weaker ones can be perfectly good and good enough to keep things under control. So
then should a maintenance dose of steroid cream be used, and if so, how often? Definitely.
Well, what we would say, so if I see a lady with a new diagnosis of lichen sclerosus, the standard treatment regime is that you use something like Dermavate, and you use a pea-sized, or whatever, I go for peas, but pea-sized amount every night for the first month, alternate nights in the second month and in the third month, and thereafter at a frequency of well, it can be once or twice a week or whatever they require to keep their symptoms under control. Now, for women who itch, then they can use their itch to guide them. So they use it every night for a month, alternate nights in the second month, and then usually the itch is gone and they're fine, and they start their twice a week maintenance or once a week maintenance. I joke about Sunday night steroid night with my patients. But there are a small subset of women with lichen sclerosus who don't itch, and we call them asymptomatic lichen sclerosus. So they have it, but they don't have the itch. Right. So clearly they can't be guided. They can't use the itch to guide them. So for them, I will just institute a regime of the same, but just say, well, look, just keep a maintenance dose every once or twice a week.
Right. Okay. Great.
And then, of course, I mean, under normal circumstances, a woman will get seen in the clinic and then has a 3-month follow-up, at which point we can then assess how they're doing. And the vast majority of lichen sclerosus responds promptly. So at that 3-month follow-up, they know what they're doing. It all looks better, and then they get discharged back to their GP with the advice that I generally say I'm more help to patients if they're having trouble rather than if they're well, because they don't need to come in if they haven't got problems. So and the GPs in my local area are very good at managing lichen sclerosus, I think. So we have a good partnership there.
Good. You mentioned vulval cancer earlier. The question's coming, when should we be concerned that the LS may be developing into vulval cancer? What are the symptoms?
Good question. So I would think, I say it's not silent, number one. It's not going to just suddenly appear and you not have known about it. It is most frequently painful. It can be a lump or a bump or a sore patch or a patch of LS. Actually, interestingly, some women report that their itch comes back that's quite at odds with the previous itch and doesn't respond to steroid. Right. That's the key. So they've got a really bad sore sort of unpleasant itch in an area that's clearly not settling with their normal regime of steroids. So that's a red flag for me, is if someone's LS is worsening, and despite it needs an assessment in clinic. Sometimes, I mean, to be fair, mostly times it's something else, but that's something I would worry about. If we say to women, report. So when I discharge women from the clinic, I give them this advice, because everyone gets told about the cancer risk when they get diagnosed, and it's one of my audit points as well. I'm discharging them. I say, be aware. So we talk about the cancer risk on discharge, and I say, be aware of the importance of reporting any changes for prompt referral back to the clinic. So if a woman has LS, if they're worried that it's not right, that it feels different, that it's not so well controlled, they need to be seen. So they go to their GP, they say, something's not right with my lichen sclerosus, I need to get seen again, and that's the right thing. And actually, mostly 9 times out of 10, it's not vulval cancer, because vulval cancer is very rare. Right. So if it's only about 3-4%, that means 96% of people are fine. But what the whole point is that because it can be so well treated if caught earlier, we don't want to leave it in the bad old days when elderly ladies have had LS for 40 years and it's never been treated, and then they have a vulval cancer which is beyond treatment. So it's early recognition, and that's why we stress the importance of getting checked out if they're not happy with it. But the things is something that's not right, or an itch that comes back that's at odds with the previous itch, or anything that's changing and not responding as you'd expect it to do with your steroid.
Okay. And what should someone do if the GP won't listen regarding their symptoms and how bad they are? What advice do you have on that?
How do that's a difficult question. Well, I mean, it's tricky, isn't it? I have great respect for my GP colleagues. They have to do so much in such a short space of time. I mean, I have the luxury of a half an hour slot for my new patients, and time to examine them, and a room, and a chaperone, and a nurse, and all the rest of it. So I think first of all, you need to be examined properly, because I know that a lot of people are just given thrush treatment. As a general rule, if you have thrush and you're treated for it, it usually gets better. So if you're told you have thrush and you're given thrush treatment and it doesn't get better, then you have to go back and say, I'm not sure this is thrush. times have changed. I think I would have said that your sexual health department is always very helpful because they can be a second opinion that you can self-refer to, but of course that's all changing now in our current climate. Certainly our sexual health system centre in Cornwall has changed hands. So what can you do? So it's a difficult question to answer because I don't know what if you have is the lady got lichen sclerosus and the GP's not referring her back? It's difficult. I mean, it really is difficult. I think if you the wonderful thing about the internet now is that, and I think it's great, is that patients are so well informed that quite often they've come up with their own diagnoses anyway. So I think if a woman is worried that they have lichen sclerosus, and they need to say that, I think I could have, I'm really concerned I have lichen sclerosus. I really do think I need a second opinion in the hospital with a dermatology specialist. And I think it's very hard. I would suspect it would be very hard for a GP to ignore that. Okay. Equally, if a woman's got ongoing symptoms, usually after the third or fourth visit, that should be flagging up to the GP. It would, in my mind, anyway, that this isn't getting better. We really do need to have a proper look and an assessment. So a difficult question to answer, but I appreciate that. And equally, I'm very blessed that I work in a part of the country where people do have access and can get to see their GP. And equally can get referred into the hospital. I mean, and our waiting lists aren't enormous. Although having said that, considering the department's currently closed, I don't quite know what it would be like when we reopen again. But anyway, aside from the current situation, yes. So I can't really comment on other parts of the world, the country. Persist. I would think, and I think it's. Yeah, persist and perhaps phrase your concerns in a slightly different way that might, one would hope, raise concerns in the GP that just need to be looked at seriously.
Okay, good.
So,
all right.
Could I have lichen sclerosus or something like that?
Yeah, brilliant. All right, white red pimples that are sore on the vulva, is that normal for LS, and how long should they take to heal?
Well, not well. Again, it's a difficult one because what is her white red pimple? I'm not quite sure. So, again, that could be sort of a normal anatomical variant. It could be angiokeratomas, which are normal, which you can have alongside having LS. Tricky. I don't know is the answer. I'd have to look. I'm not sure I can answer that one easily.
Okay, that's fair. All right. Is the skin texture different on each area of the vulva? And should we use a different strength steroid on the clitoris to the perineum, for example? To clarify this more, I found using Nerazone on the clitoris and Dermavate on the perineum better than the same cream on both. My consultant said it was possible as the skin varied on the vulval areas.
Well, I think that, I think that it's whatever. I like to empower patients to be able to treat themselves. So, and I think sometimes she's right. Nerazone is a very useful Dermavate alternative, and some people prefer it to Dermavate. And sometimes I will often switch patients to Nerazone when Dermavate is seemingly not so helpful. And if she is finding that, then that's fine, and I wouldn't have a problem with her continuing to do that. As to why, well, there are different bits of the skin. It's not just the skin can be different, but also they're in different stress points, if you like. The entrance, the posterior fourchette, so that's that bit, the entrance to the vagina there, that's under more strains than the clitoris is, or it's so. I think that's fine. If she's got a regime that works, I would be very happy with her continuing to do that. And it may well be that there's some subtle differences, but if it's working, that's great.
Yeah, good. Okay. All right. Many women are turning to borax as a remedy for LS. How safe is this to use?
I've only used borax solution for chronic thrush, actually. I've not used it for LS. I don't really have any experience of it being used for LS. Okay. I think it's a standard old-fashioned treatment for for chronic thrush.
Right. Okay.
But it's, to be fair, it's so long ago since I used it. I can't remember much about it other than that.
Okay. All right.
Other than that, Yes, it's commonly used in slime that my 13-year-old child was into making quite a while ago.
Lovely. What are your thoughts?
That's in contact lens solution. But anyway, that's
Oh, right.
it's got borax in it, I think, something like
that. So we've just got a couple more questions left, 2 or 3 left. What are your thoughts on Mona Lisa and PRP treatments compared to steroid use?
Mona Lisa, who's that? I don't even know what that is.
Oh, okay. All right. PRP treatments?
Yes, platelet-rich. Am I just being very rural and remote and not knowing what Mona Lisa is? You can educate me. PRP is platelet-rich plasma, isn't it? So they take a bit of your blood, spin it in a lab, and then inject it back into you. Yeah, I think that's the O shot, isn't it? Is that right? I don't think there's been much in the way of trials. I did have one patient who spent a lot of money to go up to London and have it. There's suggestions that it may help in LS. I know you have to pay for it, and they have lovely rooms in Harley Street and give you a nice cup of coffee. Whether it actually works or not, I have no idea. Right. She said she didn't find it a sustained benefit. But they are doing studies with fat transfer, and I know that the Royal Free are doing some work on that. David Nuns had done a pilot study on it as well, and there was the chap in Italy whose name escapes me for the minute who was doing it, and I think that's got a part to play with steroid resistant lichen sclerosus.
Right. Okay.
And that may be, I think that's kind of that sort of ongoing, shall we say. I think that's being looked into at the moment, and we may have some more concrete evidence as to whether it does work or not.
Okay. All right. So things to look forward to possibly for the future there.
I think so.
Okay, I've got a question here. Can stem cell treatment help? I've been treating religiously since mid-November, using Dermavate sometimes twice a day. The condition of my skin actually looks more fragile since using the steroid, and it's only more recently that I got tiny little cuts on my vestibule after sex, and I keep tearing on my posterior fourchette.
Well, I wondered if she was confusing fat transfer or PRP, because that's right. What I did wonder, because I'm not aware that we're going to use. I don't know. I mean, anything's possible, but as I said, I don't think I'm not aware that we're using stem cells in treating lichen sclerosus. So going to what she says further on, that she feels her skin looks more fragile and the little cuts. I think she doesn't mention her age, but if she is perimenopausal or menopausal, whether a bit of estrogen at the posterior fourchette might improve the quality of the skin down there. Again, is she avoiding irritants? Recurrent tearing at the posterior fourchette can be a real problem in LS. And I think what that leads to is scarring, which is fragile, and you can imagine of that bit where it is just right there, it will continue to split. And I think that could be a real issue. It can certainly be a big cause of painful sex in women with LS. And so we would give them a bit of estrogen topically to massage into that area to try and improve the estrogenization, to boost the sort of the elasticity of the skin like down there. That may help to some extent. There is an operation you can have called a Z-plasty procedure. I'm very lucky that I work with a consultant gynecologist in Cornwall who does that operation. And she's done over 100 or so now. And it can work fabulously well for women who just have recurrent splitting at the posterior fourchette for whatever reason without LS, and for those who have LS. And it can be amazing, actually. It can be really good. It was one of those, it was started by a chap called Jonathan Frappel, who was a gynecologist in Dereford. And he happened to be, it's a great story actually, if I've got time to tell you. It's a nice when you have colleagues who are chatting and you share information from different specialties. So he was out sailing with his plastic surgeon friend, and he was saying, I've got this problem with this poor lady who keeps splitting, and there was an old procedure called Fenton's, which wasn't that helpful. And he said, and I don't know how to get it better. And so his plastic surgeon colleague said, oh, why don't you do the same operation that we do to repair this bit of skin at the thumb? So, which you can imagine, I often use my hand as my vulval model. So it's the same kind of skin, isn't it? And so there's this, the Z-plasty is what they do to repair problems in that web space in a thumb. And so he applied it to the vulva and it worked brilliantly. So that's how the procedure came about. And it works great. And it can be very helpful. I know not all, I mean, we're very lucky in Cornwall, but I know not all centres are doing it. So
okay,
that can help.
All right. Okay. Couple more. The original site of pain, which was my external labia majora, is now pain-free. The burning I get is mostly on my vestibule.
I think that's not uncommon. I think
right.
Again, so why do people get pain? A number of reasons. In some ways, I can talk about it in terms of that the nerve endings in the skin get inflamed, hence why you get the vulval pain. But more and more, I think it's probably all down to the pelvic floor. So your pelvis is a bowl slung with muscles. And for whatever reason, back problems, childbirth, being overly constipated, abdominal operations, hip injuries, arthritis, you name it, all of that can cause an effect or affect the pelvic floor muscles, which can lead a change in the tone of the muscles, either too much tone or too little tone, and that can respond as, oh God, just in my ears, as to referred pain on the vulval skin. And that is the other way of looking at vulval pain. So in answer to the question, it's moved. Well, maybe that's a function of what's going on her pelvic floor. And I think probably the pelvic floor and getting help with physio and exercises to improve whichever bit you need to either make it stronger or make it more relaxed can be very beneficial. Right. So in answer to why has the pain moved, possibly because it's all down to her pelvic floor, or she's got something else going on and there is some soreness there that could be something else. So again, good assessment, good examination, get to see someone for, well, obviously when you can get to see someone for advice.
All right. This one here, LS vulvodynia labia removal. This lady's not happy with that. She's got scar tissue and pubic hair growing up the vagina. What to do for relief?
Well, pubic hair wouldn't normally grow up the vagina. So, I mean, unless she's meaning vulva rather than vagina. So, to me, the vulva is everything on the outside. The vagina's the vulva is the way into the vagina, if you like. Yeah. So everything on the outside is the vulva. Your pubic hair really only goes on the labia majora, which are the outer areas. Labial removal, well, wouldn't advocate that in any way, shape, nor form. Scar tissue, well, if you've had problems there. So the whole hair issue is interesting because going back to 1999 when I started work, doing vulval work, everyone had hair. it was so unusual not to have hair that we would actually write it in the notes. Has no hair, and now it's the other way around. Oh, I just got to tell. Sorry, I've been called a lot. Oh, you're back again. And now no one has hair, and now most even the men have hair, which is all very interesting. So I don't know. Some people's attitudes to hair are so different that maybe that it's not that much hair, but it's still too much hair. I don't know. I certainly advocate that pubic hair is good. I think it's there for a reason. There's lots of studies to say that it is extremely helpful at preventing sexually transmitted infections and all the rest, and keeping your skin good and all the right temperature and the right humidity and everything. So sorry, I can't really help with that because I'm not quite sure what she means.
Okay, all right. And then finally, any advice for cycling? Any creams to use for when I'm red raw after cycle training for a triathlon?
I love this question because actually at a vulval meeting a couple of years back, one of the dermatologists gave a great talk because she'd been advising the GB cycle team, particularly because you can imagine a lot of time in the saddle will lead to a very sore vulva. So it's all about the right products and avoiding the wrong products. So looking after your skin, using a barrier cream, using an emollient, avoiding creams that are irritant, and also wearing appropriate cushioned protection. So a gel seat. Sheepskin can be quite good, actually. You know, I was talking to a patient the other day, actually, in clinic about, you know, the kind of the sheepskin rugs that you lay babies on. Just because wool is very, it keeps everything at the right temperature. If you're hot, it'll be cool, and if you're cold, it'll be warm. And also, it's very cushioned. I thought she could just make a sort of like a pad to pad her out, see if that would help. But yeah, you need to cushion, you need to protect, you need to use a good emollient and a good barrier cream, basically.
Right, fantastic.
Good.
Right, well, I think we've come to the end. We've managed to power through all of the questions we got in. I think Excellent. We've covered them in some form or another. Really good questions, and
yeah, they were very good questions.
Really, really grateful for your answers too. Any final words before we finish up today?
I think it's the basic principles of vulval skincare: avoid irritants. Use a good moisturizer, avoid soaps, use a soap substitute, and if you need a steroid for your condition, use it appropriately.
Wonderful.
And then add in estrogen if you need it as well.
Okay, fantastic. Dr. Liz Venner, thank you so much for your time today. Thank you everyone who's joined us. I think at its height we had 39 people join us. Everyone will get a recording of this, and those who registered who weren't able to join will also get a recording of this. Our next live Q&A will be next Friday the 24th, again at 2 p.m. And we'll have a physio for everyone. So again, sending in questions for that. And if you have any questions that have come up as a result of today's Q&A with Liz, do feel free to get in touch with us at the Vulval Pain Society.
info@vulvalpainsociety.org.uk.
And I will hopefully see you back here next week. There'll be another registration link just to make sure it's all secure, and hopefully I'll see you then. Bye for now.